And welcome to today's webinar. My name is Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you to everyone for attending today's webinar, our second in the fall leg of our 2025 webinar season. If you're new to our webinars, a little background on our group. CACSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit survivornet.ca. This webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. We'll have a quick Q&A session at the end, but if you would like, please put your questions in the chat function at the top of the GoToWebinar window. This webinar was made possible by grants from AbbVie, Amgen, AstraZeneca, Eisai, Bristol Myers Squibb, Jensen, and Merck. Because of their continued support, we can host the CC10 webinar series and thank them for their commitment to our educational endeavors. And now to introduce a return guest of ours, Don Husro is an adjunct professor of medicine at the University of Ottawa. He does freelance healthcare research and works with private and public sector life sciences organizations to help them understand the value of health technology and its implications for health and innovation policy. And so without further ado, I'd like to hand it off to Don for his talk, Canadians' Healthcare System Preparedness for the Future of Complex Interventions, Lessons from T-Cell Redirecting Therapies. Take it away, Don.
Thank you, Trevor. That was thank you very much for the opportunity to speak, and I'm very happy to be back again. I think a lot of what I do, I'm always thinking about ultimately the patient experience, and the health of patients, and so I'm very happy to be here. The talk that I want to give you today is about something called a complex intervention. It's something you may or may not have heard from, and we're going to use T-cell redirecting therapies, something you may have actually heard from about in the past. There have been past webinars about these, and we'll talk about that too. So as was mentioned, I'm Don Husro. I actually used to work with CADA, even when they were CODA, with CDA-AMC, back when they were both CODA and CADA for 10 years. I've also served on expert review committees, including the Pan-Canadian Oncology Drug Review Expert Review Committee. I was a health economist, and also with the Government of Ontario, their committee to evaluate drugs. I'm originally a pharmacist by training, but through years of working in health technology assessment, I've gained more expertise in both health technology assessment, health innovation policy, and health economics. And this is the kind of research that I enjoy doing. I have also worked with both public sector and private sector organizations over the years, and the sponsors of the research that I'm about to present to you were actually Amgen Canada, J&J Innovative Medicine Canada, Roche, and Pfizer. So this may not be news to some of you. I'm not sure. These are what we're calling T-cell redirecting therapies. It's more of an umbrella term for what we now have available as bispecific T-cell engagers, including drugs like Epkinly and blinatumomab, and also the CAR T therapies, which you may have heard more about. The idea behind a T-cell redirecting therapy is each of us has in our body a white blood cell called a T cell or a T lymphocyte, and these things play a very crucial role in the body's immune system, helping identify and eliminate cancerous cells or just foreign invaders, infectious agents, and the like. And they're constantly surveilling and working within our body to protect us. But when we have cancer or some kinds of autoimmune diseases, the theory is if we can change the behavior of those T cells, we might actually improve health outcomes. So this depiction here is depicting both the bispecifics on the left and CAR Ts on the right side boxes, CAR Ts are a little more involved. They require extracting your T cells, re-engineering them, and then putting them back into you. The bites simply are injected into your body and change the behavior of your T cells by bringing your T cells in closer proximity to other parts of your body, including, for example, cancerous tissue. And this slide comes from the report. There's a QR code on a lot of these slides that just will link you to the report. The Health Canada approved therapies are this top area here. These are the CAR T therapies that we have currently, largely for hematologic cancers. And the bispecific T cell engager therapies are here. If it has an asterisk beside it, it means it's not funded yet, but these are Health Canada approved therapies. And you'll see just about all of these are blood cancers, as I mentioned, except for this one right here, which is actually for small cell lung cancer, which is approved by Health Canada, but not yet reimbursed by our provincial drug insurance or cancer agencies. These ones on the bottom here, though, are all the things that are coming. Sorry. So they're investigational. They're right around the corner. This is a selected list of things that will probably be here in a short amount of time. And we're getting into things that are for solid tumors, gastrointestinal cancers, etc., and even for some autoimmune conditions. These are sometimes variations of what we see up top here, CAR T therapies, but some of these are actually different in terms of how their proposed mechanisms of actions are. And so all of them, though, ultimately affecting T cells. We think about these interventions as what we call complex. And that's because unlike a traditional therapy, which is largely context-free, I get the pill, as long as I take it, I get the benefit. The benefit from these therapies relies on a number of factors that are beyond just the pill. It relies on specialized personnel, relies on collaboration across health service delivery programs. It relies on scheduling. It relies on laboratory testing done in a timely fashion, etc. So we think of them as, we call these things complex therapies because it's not just the therapy that matters, but it's the education, the timing, training, scheduling, and all the host of other factors that actually can affect ultimately the effectiveness of the therapy. And these things are here and growing. This is actually a graph of the annual number of patients who qualify in the public system for CAR T and BiTE therapies, the currently available T cell redirecting therapies. Years ago, we had a drug called blinatumomab. It was largely used in pediatric blood cancers. But since then, we've had the introduction of a whole bunch of other things. And you can see that the potential use of these things is on the rise, and it's just going to go further on. So it is something that policymakers should be paying attention to. So as I already mentioned, complex therapies are context dependent. They're defined by these interactive components. They rely on the behaviors and training and other factors to actually be effective. I just wanted to point out also from a regulatory perspective, from Health Canada's perspective, they do think about something called an advanced therapeutic product. This is what CAR Ts are considered for the most part. These have a different definition. They're personalized, they're developed at the point of care, they're manufactured, distributed in ways that are different from traditional health products. These products are typically complex, but not all complex therapies are going to be advanced therapeutic products, and not all advanced therapeutic products are going to be complex. But I just wanted to make sure the distinction was there. And there are other examples of complex therapies in the realm of infectious disease. We have something called a fecal microbiota transplantation. We already are aware of stem cell therapy or stem cell transplantation. That's a complex therapy. There are new gene therapies coming in. In the realm of diabetes, we have systems that rely on sensors and machines and devices linked to medication. Those are a type of complex therapy. I mentioned CAR Ts and bites. You can also think of other, there are other things as well that are more complex. Ultimately, because these things rely on a bunch of moving parts, the healthcare systems have to have these parts in place. So when we think about, whether we're going to see patients getting the effectiveness of these treatments, it's not just is somebody paying for the treatment, it's are all the parts in place? Do we have the treatment facilities, processing facilities? Do we have trained personnel? Maybe we need a regulatory framework to make sure that these things can be easily approved, or more readily approved, or more consistently approved. Do we have laboratory capacity? What about maybe we need informatics? We might need other things, shipping, couriering, scheduling, a bunch of other factors that have nothing to do with whether or not I am paying for the drug. And that's the point that, that we're trying to unpack, is the role of complex therapies and whether or not health systems are truly ready for them. And there are examples outside of healthcare that we can get our head around in terms of a kind of complex innovation. We think about, or just something that's very disruptive, that we think about video conferencing, which, for a lot of us, post-COVID has become the norm. It actually, has changed not only how we do business, but where and how we live and how we drive and commute and what we can do. But to be ready for video conferencing, the system had to be ready. And it just so happened we were ready. Around the time of COVID, we had high broadband internet, we had high connectivity, we had cloud platforms in place, we had the processing capability of our computers, and highly functioning and inexpensive cameras and microphones and the like. So all of those factors made us ready to take on this new technology, which has been transformative. And so I think when we think about complex therapies, we should be thinking about the same thing. Is the healthcare system do they have all the factors needed in order to take these things on? And when we think about readiness, we should be thinking about readiness on using a few different dimensions. So one is the healthcare system ready to consider a new innovation? Typically within the realm of drugs, we are ready to consider. We have systems in place like our Health Canada, our regulator, but also our provincial reimbursement function, the CDA AMC, for example, as a conduit for considering new proposals for new drugs. What about adopting and financing? Well, most, again, within the realm of cancer, most provincial cancer programs have drug formularies. They have people overseeing formularies. And so that gives them the ability to adopt new therapies. But now we're getting into things like financing. Well, traditionally, that formulary manager would be responsible for paying for that drug, just off the shelf kind of thing. Maybe they'd have to also think about the additional costs of preparing the drug, if it's, for example, an intravenous drug. But now they may have to think about a whole host of other things. The CAR T, it's not just paying for the drug, it's paying for an apheresis appointment, it's paying for nurses, it's paying for the shipping of samples of T cells to and from, it's paying for the reinfusion of the drug, it's paying for toxicity management and monitoring. So suddenly the finance, we may not be ready to finance in this realm. I should say there may be technologies that even challenge how we can consider new things. There might be things that are not drugs or that are drug devices that even make it difficult to consider the new innovation, and never mind adopt. And there may be no programs in place to adopt certain technology as well. But in the realm of new cancer T-cell redirecting therapies, those things are covered off. And finally, to deliver and monitor how we're delivering, we may have to change the way we do things entirely. And these T-cell redirecting therapies require a lot of extensive monitoring. It means that the schedules of physicians have to change. It means that people have to be trained, or protocols have to be in place to manage toxicities. It means that emergency departments have to be on notice. It means that, and as I mentioned, if you're using a CAR T, it means we have to also think about the scheduling of the apheresis and the reinfusion, and in relation to when we think cells are going to be manufactured and the like. So there's a bunch of things we may have to reconfigure how we traditionally deliver the service in order to get there. Again, we can think about this in terms of T cells, but there are going to be other complex therapies in the future where we may have to think of a whole host of things that fall under this. Traditionally, healthcare systems have been very reactive to any new or disruptive or complex therapy. Once it arrives, they say, okay, how are we going to deal with this? And they have to deal with this through change. They have to maybe change the way they consider new innovations, or change the way they adopt and finance them, or change the way they deliver them. And it's helpful to have an organizational change management function, somebody who can actually help facilitate that change. If they don't, if they truly just react and then try and figure it out, well, it seems like it's a costless thing, but it's not. And this is where patients can be disenfranchised. In this report that I've recently conducted, we looked at just what's around the corner with T-cell redirecting therapies, and there's a number of them around the corner. And then we said, how about we just focus on the things we really know are coming, and where we have some information about how effective those agents are, and that are going to be very useful in people who are going to have very severe prognosis, people who will suffer either in terms of a risk of dying or severe illness within the next 6 months. And now let's ask the question, if we delay, if we're not ready to change the system, and it creates a 6-month, you could say, unnecessary delay, what is the human impact of that? And this is where it becomes very important. If you're not ready to change the system, if you don't have a readiness for changing the way you consider, adopt, finance, deliver, you can ultimately affect patients. And so what I did was create a very conservative scenario of real changes that are about to happen in the realm of diffuse large B-cell lymphoma. We're going to see the use of these bispecific T-cell engagers go from 3rd line to 2nd line. And that means that the population is going to expand quite a bit. That means the system may have to change to accommodate this expanding population. There are some systems that are sort of already at capacity. What about CAR Ts? Well, we know for sure we're going to have CAR Ts for relapse refractory multiple myeloma that go from a 4th line setting up to a 2nd line setting. Again, a ton, many more patients, 441 to 2,000 more patients in Canada annually. If we delay 6 months, we could have the loss of 20% of patients who are alive without disease at 6 months. So we can calculate life years, and we can actually put a human cost on this. But it basically tells me that in a course of 6 months, there's 1.3 years of life loss for every day of delay in access to these therapies. And there have been other analyses done to look at the cost of delay. And this is sort of using a similar type of approach. So in order for healthcare systems to be ready, to be truly ready, they do have to address a number of questions. And we use this broad term, we could use the broad term implementation, right? Are they ready to implement? But this is a loaded term because it constitutes, again, a number of things that I've already mentioned. They have to be ready to consider new ideas. As I mentioned, in the realm of drugs, we do have the CDA-AMC function or the NS function to help consider new drugs. But you know, there are people who show up with things that aren't drugs, and suddenly even the consideration of that new thing is a challenge. We have to have systems in place to adopt. Between considering and adopting, we have to think about planning for change, and we have to think about bringing together necessary people, engaging. We have to think about how the evaluation function, do we have that built in? Sorry. And then once we decide to adopt, we have to be ready to execute. So we have to consider all these healthcare system parameters to deliver this new therapy. And we're going to have to ask ourselves questions like, do we have enough nurses, or do we have an apheresis suite that capacity to deliver, or do we have, you know, are the emergency departments prepared to deliver the toxicities associated with this? Or, you know, with some of these therapies, they're going from blood cancers to solid tumors. Are these solid tumor specialists going to be comfortable with these kinds of things? Just as a nominal example, this is CAR T, and you think about all the, because it's complex, it has more barriers to sort of optimal adoption. CAR T patients have to be screened in. It's not just anybody that can have it. So there might be access issues for patients there. Then they have to have this apheresis procedure. That requires maybe a specialized medical center or program that they're going to have to get to. They may have to travel from out of town to get that done. We're going to have to get these CAR T cells manufactured. That requires, first of all, commitment of resources to do so by the province. But even the people manufacturing these may have only a limited number of limited capacity to manufacture these therapies. And in the meantime, these patients also may need some therapy to get them to the point where they can actually have the CAR T therapy. Then the therapy has to be administered. And because of the potential for toxicity, it usually has to be administered close to a critical care center in case a life-threatening thing happens with these therapies. That means that people have to travel in from far and wide. That means they probably have to have an informal caregiver or some type of support. So there's a number of things that have to happen and line up in this perfect world for a person to benefit from these therapies. Gives you an idea of, you know, some of what happens when we are adopting complex therapies. And if we see increased utilization of these, we might see situations where right now the health system is okay, they've been able to adapt, but there might be a lot less flexibility in the future to actually increase capacity in and around use of these. So then they're going to have to think about alternate solutions. Well, if we can't have every patient, you know, these drugs actually require patients to be admitted to hospitals in some centers. Well, if we can't do that for every patient in the future, we're going to have to think of some sort of hybrid solution. We can't do it outside of the hospital, but we can't do it in the hospital. So maybe we create some sort of special stay unit. But that then requires planning and organization and organizational change. We have to think about monitoring. Well, we could have people monitoring them 24/7, or maybe there's a way of doing it that combines maybe a remote nurse with some sort of telehealth technology. They have to have access to critical care services. Is there a way, is there an alternate approach, or do they really have to be near an ICU. And, you know, no surprise to anybody here, the more of these therapies get introduced, there's going to be much more costs associated. Always a potential barrier to their introduction. And in the case of these therapies, ultimately you have, you know, they create more activity. It's more movement for patients and care providers in order to successfully to benefit from these therapies. It doesn't make their lives necessarily easier in the short term, and it could make them a little more challenging. So knowing all of this, and in this research, what I did was I spoke to a bunch of folks who were either patient representatives or healthcare system administrators. Also spoke to a bunch of healthcare providers in this area, and we actually had a multi-stakeholder roundtable where we discussed some of these issues. We asked participants to talk about whether this is a problem and how big of a problem is it, talk about some of the unmet needs and barriers, but ultimately identify like what needs to be done, and with the lens of not only what needs to be done with these T-cell redirecting therapies, but as we think about other complex therapies going forward in the future, what is going to be needed as well. And so that was the crux of what I was looking at. And I heard a lot about potential barriers. So I've already mentioned some of them nominally, that, you know, and things that had been written up by others. But as I spoke to people, I did hear about a number of barriers. Now, this varied by province, from province to province. But, you know, one significant was, and we heard it across a bunch of provinces, is that there was a bit of a worry that people who were responsible for the healthcare service delivery administration part, the people who are thinking about where's the healthcare system need to go, don't really know where it's going to go. The clinicians are much more in tune with that, and they're the ones that are not only caring for patients, but having to drive change in the system. Bit of a double whammy. They're having to consume their bandwidth trying to drive change, which also then takes them away from important patient care. Obviously, that speaks to a solution of, you know, could we have other people trying to drive change in the system rather than simply the people who provide this tremendous value to the system by caring for patients. We heard about other aspects. I'm not going to go through each and every one of these, but the other one was the inadequate model of service delivery. We heard again and again that things like the cancer center doesn't want to actually see them because it's after hours. They want to close after business hours, and the health region has a new model on how to deal with outpatient care. So outpatient care is a big concern for cancer programs and for healthcare systems, because inpatient care is costly. It's resource intensive, but it also is. We have, you know, limited capacity. We may have, what I heard from people is, look, we just figured out how we're doing inpatient, outpatient care, and now this new technology has come in and challenged that paradigm. And so now we have to rethink it all over again. And that was one example of an inadequate model of service delivery. We also heard from hematologists who, as I said, and as I mentioned, these T-cell redirecting therapies are being largely used in blood cancers, but are around the corner, will be used in solid tumors. The hematologists were used to a certain type of schedule and doing a lot of on-call, but they said their solid tumor counterparts weren't necessarily used to doing that type of thing. And yet, with the introduction of these new therapies, their schedules were going to have to change. So that creates a tension in terms of what's the service delivery model for solid tumors and how is it going to have to change. We also heard the patient perspective, speaking to patient representatives, and, you know, one comment was even how these therapies are presented to patients can be challenging. I just described this therapy as taking your cells out of your body and modifying them and putting them back in. And people have concerns about that. They don't want to become the Spider-Man. They worry that, you know, what's really going to happen there, and is it going to change me as a person? Those things have to be. So, you know, one of the aspects of care here is we need good, not only good patient navigation, but good patient information, standardized patient information, and clear and effective ways to communicate so that the patient ultimately is going to receive the full benefits of treatment, and, you know, not drop out or opt out halfway through because of concerns from an uncertainty that they have because they simply just didn't have all the information they needed. So the group that sat down in May basically generally thought there was a lack of preparedness for this future of T-cell redirection therapy. Doesn't apply to every province equally, but felt that healthcare system leadership is going to have to better address the complexity of delivery, the need for personnel, and some capacity issues. And in some provinces, we heard loud and clear there were going to be tremendous capacity issues. As we get into solid tumors like melanoma, this could create challenges because up till now, these types of therapies are delivered often through hematologic and stem cell transplant programs. So now you're getting into other specialists who aren't, you know, working within those programs. And so that's going to be a kind of sea change and require adaptation. We did hear also that, you know, if you try to pay for these therapies the old-fashioned way, you know, a traditional chemotherapy would just be, well, how much does it cost to procure it, and some additional costs around preparing it into the IV bag. But this is much, much more. This requires training. I already mentioned informational needs, toxicity management, care navigation, coordination, and patients have to come in to take these things. And, you know, I did hear from different provinces. Some provinces were funding patient travel, some were not. And so, or, you know, sometimes patient travel is funded through the support of NGOs or even, you know, the pharmaceutical companies themselves. But ultimately, you need to have a sustainable solution for finance. Some of the recommendations that we came out that we think apply to not only T-cell therapies, but to complex therapies at large are the following. One, it should be potentially obvious. I mean, if I point out to you that healthcare systems are seen as largely reactionary and respond to things, and by responding late, it could have a humanistic cost, it tells you that you need to have an anticipatory function that is focused on changing governance and service delivery models in the healthcare system. Something where people are looking ahead and saying, okay, we're not prepared to deal with this. What needs to change? And so having an organizational change function and leadership focused on organizational change is going to be probably increasingly helpful in the future, in a future full of complex therapies. These organizational change functions can also think about how do we adopt, you know, things into a system. We don't always have to do widespread adoption at the beginning. We can think about it in a stepwise fashion. Think about programs that look at adoption, spread, scale, and sustainability. So, you know, beta tested in a center before you go prime time. Again, another lesson for complex care was you may have to think about creating specialized programs of care. So another complex form of care is hemodialysis, and in most provinces there are specialized renal programs. So no big secret here. And they had to do that so that they could bring in the necessary components of the healthcare system together to work in close alignment to deliver that complex intervention to people who are in real need. Well, the same is probably going to be true of cell and gene therapy in the future. And so, as part of that healthcare system level oversight and that organizational change management function, they also have to be considering whether they need an entirely new program of care to make sure that the left hand is talking to the right hand, that there's coordinated service delivery, that they can appropriately plan for the future. Cancer programs in and of themselves are a specialized program of care. And then within those programs, there are even more highly specialized programs. A third thing is in regards to processes to develop and evaluate technologic developments. I think it's important and incumbent on all healthcare systems to have a function that's forward-looking and thinking about the value and implementation of future interventions, borrowing from best practices in both implementation science and health technology assessment. The more transparently and inclusive, and with more inclusivity they can do this, the better. A fourth recommendation, although this could apply to anything, but it certainly does apply to this new world of complex interventions, where as I said, the effectiveness and the cost effectiveness of the intervention really depends on a whole bunch of moving parts. How do you know you're getting what you paid for? Well, you do that through data collection, through the ability to evaluate the costs and effectiveness of that intervention in real time. And so, as we get in the world of more complex interventions, we shouldn't just be thinking about can we deliver them. We should be thinking about can we deliver and monitor their use and their impact. And that could be helpful then in tweaking and changing how we go. And finally, we do have to revisit sometimes the financing approach to these programs, whether that be through thinking about some sort of small scale initial financing, but also what we heard was, for example, if a new therapy comes in and requires a whole bunch of additional toxicity management, well, in some jurisdictions, that's a cost add for the hospital. So we need to think about how we're going to compensate other parts of the healthcare system for the spillovers that a new technology might introduce. So that's it for this research. I'm right now in the midst of sort of communicating the results. I think my feeling is the report is only a starting point. Really, what we need to do is have further discussions, not only about T-cell redirecting therapies, because I think it'd be a bit short-sighted just to focus on those, but also this larger aspect of the future of complex therapies, which may or may not even be part of cancer care. You can find the report, as I said, using the QR code, but you can also find it on the Resilient Healthcare Coalition website. And I do hope, and I appreciate your feedback, your questions, your comments, your concerns about this report. And I do hope it's useful to you. And I thank you very much for your time.
Wonderful. Thank you so much, Don. That was a very, very good presentation. And if anyone has questions about the presentation, feel free to put it in the corner on the GoToWebinar tab at the very top. I guess my first question, while we're waiting for other people to have questions as well, is what in your, I guess, probably subjective view, especially talking to healthcare professionals, is what generally do you find is the appetite for change like? Like, is it a strong appetite that just requires, that is a lot of work, or are people a little bit more on the setting in their ways kind of ways?
I mean, I think we'd be mischaracterizing healthcare systems as saying that they're sort of inert and they don't change. They do change. I think the point we're trying to make here is sometimes they need to be prepared to change in a more rapid fashion. But the reason it's difficult is just because of how they're organized and because maybe they don't necessarily have any change leadership. So you can imagine in a province like Ontario, it's quite a large healthcare system. It's like a bigger ship. It might be harder to turn the ship sometimes. And so we've seen that, I've spoken before on genetic and genomic testing. It's taken them a long time to get their act together on that, as opposed to maybe a smaller province that has, far fewer people, and far fewer people involved, and it might be a little easier. So I think there's always an appetite for change. Change also inherently has its own costs. And so, because, and we've all worked in organizations, like if people are changing things all the time, it does create a kind of inertia as well. We have to be really careful about that too. So that's why change has to be carefully managed. But we're going to require more change, obviously. So I think the main point we're trying to make is there should be more emphasis on change management. It shouldn't just be some passive exercise.
Excellent. GM sends, when do provinces prefer to start the change process to get ready? Early is always better, but it's a bounce on how to prioritize.
Yeah, I mean, and I've, you speak to sometimes an innovative company and they're saying, well, can't they see this is coming? Why wouldn't they prepare for my new widget? But, the truth is there's a lot of things that have been developed which never land, which just, for whatever reason, don't ultimately get adopted. So, and I do think healthcare administrators kind of know this. They sort of know they can't prepare for every single proposal that comes along. They'd be constantly changing, but there is a threshold. I mean, you saw with the T-cell therapies, they're here already, and there's way more coming. There's undoubtedly there's going to be more of this in the future. I think there is a way of anticipating at least some key things that are coming. Gene therapies are coming. So I don't know which ones are coming, but I know that gene therapies are coming. So that's going to happen.
I was about to ask you if you could see anything that's similar on the horizons, but again, as you said, gene therapy is coming, and I believe that you have talked with us a little bit about gene therapy as well in the past. But is there anything else you can see on the horizon that would really benefit from this kind of process being implemented in the near future that you can see?
I think gene therapy and cell therapies are coming. We're going to see, I've talked about advanced testing right now focused on genetics and genomics, but we're going to have potentially in the future broader applications of proteomics and metabolomics. So we're going to have these types of testing. They're coming. It's like, it sounds like I'm just saying only gene and cell therapy. That's a lot of stuff that's coming across a lot of therapeutic indications. There probably, there's going to be more. There might be more outside of cancer as well. In terms of, there's going to be more disruptive therapies coming for ophthalmologic disease and diabetes and the like. So, we're hoping that some of these lessons also are taken up by people outside of the world of cancer as well.
Mm-hmm. All right, so I think that is all the questions we currently have. Once again, if you want to chat with Don, we'll have ways to get in contact with him just to get some feedback on this information. But Don, always a pleasure to have you. Thank you very much for your time. It's been a fantastic webinar as usual. And once again, just packed with information and very current information as well. So we really appreciate you sharing it with us and being on yet another webinar.
Thank you so much for having me, and it's a pleasure to be here, and I look forward to anybody reaching out. Thank you.
Mm-hmm. Now, this webinar was made possible by grants from AbbVie, Amgen, AstraZeneca, Eisai, Bristol Myers Squibb, Janssen, and Merck. Is because of their continued support that we can host the CCSN webinar series, and thank them for their commitment to our educational endeavors. Now, this is one in a series of webinars that we will be presenting this fall. We have a ton on our website. So our next one is happening next week. So to stay in the loop on our webinars, visit our website and check your email for our e-blasts. If you're not seeing our emails in your inbox, please check your spam folder because we do use a third-party email service. We also have some issues with sometimes that the spam folder goes through. But if you found that you're not getting our emails, feel free to go to our website, survivornet.ca, to sign up for our newsletter, and you can not miss out on everything that is happening right here on CCSN. And just a reminder that all our webinars can be found at survivornet.ca/webinar or on CCSN's YouTube channel. So thank you very much, Don. Thank you very much, everyone, for attending, and we will see you on the next one. Have a good afternoon.
Thank you. All right. Thank you, Trevor.